Hello, everybody. Welcome back to the podcast. I haven't done a Rheumatology Physio podcast in a while. Just various other things been going on. But this one has been in the books with Carissa Jones for, let's call it 9 months. I participated in her study, which she'll explain about a little bit in a minute. So I'm outing myself as a participant there. We're just going to talk about what she found, what she did, what she found, and anything particularly interesting there about those outcomes and what we can learn from that, I suppose. Chris, just for everybody, just introduce yourself a little bit for us, and then we'll get cracking talking about this research that you did.
Okay. Hi, everybody. Hi, Jack. Thanks for having me on the podcast today. I guess your listeners may already figure out that I'm not originally from the UK. I grew up in Oz and did my undergraduate training over there, and worked over there for a number of years before I moved over to the UK in 2016. My background is predominantly in MSK physio. So I've worked in a number of roles since living here, and over the last couple of years I was working as a first contact practitioner in primary care, and also doing my MSc part-time in musculoskeletal physio at Coventry Uni, and it was the dissertation research project that was attached to that led me to meet yourself, Jack. In my current role, I work as an advanced practice physio at the Midlands Partnership Foundation Trust.
Wonderful. So you've really gone for it, is my opinion on you doubled down on MSK and being very highly qualified, as opposed to me being very niche. I know, though, people ask me what do I do, and I do very small amounts of things in a very niche area, but you've really gone for it on the research. Tell me just very briefly what the MSc that you did. Tell me just a little bit briefly about that, and then we'll go on to obviously talk about the dissertation. So what kind of things did that cover, and, sort of what is that leading to, I suppose?
I suppose it was a broad musculoskeletal physio program that I guess helps clinicians being able to progress towards more advanced practice roles, which is ultimately where I wanted to move towards. So it was really a lot of focus around sort of complex clinical reasoning and diagnostics, and really be able to sort of embed that within the appropriate evidence base as well. So I think that it was a brilliant course, and I think it was great that I already had a bit of a pre-existing interest in rheumatology, so I knew I wanted to do my research project on that. So it was nice that I was able to have the opportunity to explore that, really. So I guess in terms of the research that I decided to do, I guess it's probably useful to give a bit of background as to why I eventually chose that topic. I think I found I already had a bit of an interest in sort of axial spondyloarthritis, and I found it interesting that there'd been a lot of advancements, I suppose, in the understanding around the pathophysiology and the kind of pharmacological management of axial spondyloarthritis, AxSpA, over probably the last 10 or 20 years. But I guess it was still posing a significant diagnostic challenge to healthcare professionals in clinical practice. And when you look at individuals with AxSpA, they often have a lengthy delay to diagnosis. When you look at the data, globally, this is an issue. In the UK alone, people are often waiting up until 8.5 years from symptom onset until when they get a diagnosis. So, when you actually look at it, that's really changed a lot over time as well. So I was kind of curious as to why that was. When I looked into it, there was a lot of reasons why that was the case, and it was really quite complex. But there was, I suppose, a key contributing factor to that delay was that there's a delay in referral from primary care to rheumatology. And the research shows that individuals with AxSpA prior to their diagnosis will have multiple consultations in primary care. And then alongside the other research, it shows that healthcare professionals like GPs, first contact practitioners or FCPs, physios, chiros, osteos, even kind of consultants in other specialties, they often have limited knowledge and awareness of AxSpA. So those things in combination are suggesting that there's opportunities that are being missed earlier in the patient journey to be able to identify it. And the thing is that, I mean, it's important that the earlier we can identify these people and refer them to rheumatology and get them medical management, the better outcomes they're going to have. So, it was kind of showing that the AxSpA was perhaps being overlooked. And when you look at the first contact practitioners or FCPs, they're now commonplace in primary care. It's important that they have the appropriate skill set to be able to recognise AxSpA and then be able to promptly refer to rheumatology. So, I guess if anyone's not familiar with what an FCP is, first contact practitioner, it's basically a specialist MSK practitioner, predominantly from physio backgrounds, that work as the first point of contact in primary care for any MSK conditions that would have historically been seen by the GP. So they kind of assess and diagnose, triage and signpost patients. And the model of care has really been shown to be really quite effective, and it's going to be continued to be pushed out across the UK in the coming years. So I think the FCPs really, they have the potential to be playing a really important role in the earlier recognition of AxSpA, given the fact that they're working on the front line in primary care. But the fact that we know that they're finding it tricky to recognise it, I wanted to know a bit more around why that was the case, and what we could be doing to then help to make that process easier. So that's why I decided to do a qualitative study that looked at exploring the perceived barriers and facilitators to the identification of AxSpA by FCPs. And I did that by interviewing physios with expertise in rheumatology, and that's where you came into the mix.
You cold emailed me, as if my memory serves. It's kind of, you type in rheumatology and physio, and I tend to come up top of the list. Just you obviously anybody who, if people are listening to this podcast, are guessing they know who I am and have some awareness of what I've done over the last 5 or 7 years. And what you've just explained is basically a qualitative study in the things I've been saying on the internet for the last 5 to 7 years, and the best outcome for me, and you'll tell me the results of this later, but the best outcomes are that everybody needs to do my course, because obviously that would be financially beneficial for me. But anyway, I think just to pick up a couple of points you made that I really want to highlight to people if they're fresh to this, is the delay to diagnosis is one thing. It's the not improving part for me is the real sticky issue here. So, like, as you mentioned, 20 years ago, it was about 8 or so years delayed diagnosis. 2020, I think that was the most recent one in the UK where we had good data, was still 8 odd years, and it's not. And there are reasons for that, as you've sort of alluded to, but it's not improving. And then the other component to that is, as you mentioned, is they're seeing multiple people before being referred into rooms. I think the average is 6 different clinicians, and about 11 appointments, I think, if my memory is about right. But it's this opportunity cost that as you mentioned. So it's, whilst it's like, the missed diagnosis to me seems a bit harsh, but it's this missed opportunity to further investigate or refer, and then the delay to diagnosis then obviously has the poor outcomes. So yeah, I really wanted to be involved in the study, and I did set up the interview date with you, and I'm really glad I did, because it really, the way you spelt it out was exactly what I've been trying to sort of deliver information on over the internet. But anyway, so lovely stuff. So then tell me exactly what did you do? So obviously this is a qualitative study, but just to give us a little bit of an explanation about what the process was for generating your data.
So I guess I recruited participants from various means. I suppose there was kind of research advertisements through sort of social media channels, but also through professional bodies like the CSP and sort of special interest groups attached to that, through the likes of A-Stretch and NAS. They were really, really supportive. So there was quite a few means to be able to reach quite broadly to recruit participants that way. And then it was just virtual interviews. My aim was I would have liked between sort of 6 and 10 participants. I was lucky enough to get 10. I was really fortunate with that. So I got really lovely kind of breadth of data from that. So yes, it was the interviewing part was great, because it just means I got to pick the brains of some of the brightest sparks in rheumatology. I was really, really fortunate and get their insights into it. And the tricky part was probably then trawling through all the data after that and trying to make some sense of it. And I guess it was almost eventually kind of grouping them into sub-themes and then main themes that kind of emerged for barriers, and main themes that emerged for facilitators. So yeah, I'm happy to talk around what those themes were. But yeah, it was kind of just eventually kind of clumping things together into these main themes that seemed to kind of emerge from the data.
Yeah, and I can imagine you generated a lot of content. I remember we talked for maybe 45 minutes.
Yeah, that sounds about right. So yes, there was an
10 lots of
lot.
That. Yeah.
An awful lot of data to sift through. But like I said, because I was able to get 10 participants, it just meant that I had so much rich data. And it was, it was easy to be able to kind of support some of these themes, because I had all that lovely, rich qualitative data to be able to back that. So yeah, and then it was, once you'd had those themes, and it was a discussion of how that all fits into the broader research. But yeah, that's kind of where it was.
Awesome. Great. So let's start on the positive notes then, shall we? Let's start with the facilitators. So what were the broad themes that came out for the facilitators?
It's probably, if you don't mind, Jack, I might actually start with the barriers. I think it sometimes almost gives, if we kind of identify the obstacles, sometimes it's then easier to see where we need to go to overcome that. Does that make sense?
Yeah, absolutely.
So I guess, as much as I want to start on the positives, but how about we'll move towards that. In terms of the barriers, there was kind of 4 main themes that seemed to come out, and these main themes were kind of in keeping with some previous qualitative research that was looked at in GPs in the US. So there was disease-specific factors, there was patient-related factors, clinician factors, and then system factors, so things like in the environment that the FCPs are working in. So when it came to things like the disease factors, I guess participants identified that there are various factors around the disease process itself that can make it really tricky for FCPs to be able to identify it. I guess like the heterogeneity of AxSpA, in the fact that it can be highly variable in the way that it presents. And also it was flagged that these subtle nuances of the earlier presentations can make it particularly hard for FCPs to identify it. I guess also AxSpA is, it's an uncommon cause of a common problem. You think about how often back pain is going to be coming through an FCP clinic, and the vast majority of that is going to be mechanical back pain. But if the FCP doesn't have that skill set or that knowledge about how to differentiate between inflammatory back pain and mechanical back pain, then that could mean that they're kind of being misdiagnosed as mechanical back pain, or sometimes other chronic pain states like fibromyalgia, particularly in women, because they often have that less typical pattern, where that sort of more widespread pain pattern, sort of greater fatigue, etc. And also it was kind of flagged by participants that they felt that maybe FCPs were okay at recognising kind of your barn door ankylosing spondylitis pattern, but I suppose the more subtle presentations, or anything involving more the extra-articular manifestations or peripheral presentations, so things like uveitis, enthesitis, psoriasis, inflammatory bowel conditions, that was perhaps where they fell a little bit short. And I guess there was also this discussion around the fact that there's almost these outdated myths that perhaps persisting as well, and that kind of is often around that gender distribution myth. They've thought that it's been predominantly male condition, whereas in reality we know that it's more of a 50-50 split. this assumption that I guess that all axial spondyloarthritis is AS and closing spondylitis. So this idea that all of it is will show radiographic changes, where then they're kind of missing out on this non-radiographic cohort, which can make up a significant portion of who we're seeing. Just means that they're going to be kind of missing that. And then I suppose also this myth that they need to have positive inflammatory markers, that they need to be HLA-B27 positive. So if patients aren't, then they're potentially going to be overlooked as something else. So I guess all of those things in combination can make it really hard for FCPs to be able to identify it.
Absolutely. And we'll come onto this in a minute, but then, like you said, it's the environment within that as well. So you've got, this complex condition masquerading as a very common condition in a short appointment time, typically short appointment time. And we probably talked about it in the interview. I'm very lucky that I set my own appointment times. I have an hour with patients, but FCPs don't have that period of time. So you picking that up as well. Yes, obviously I would agree with all of those. Of those. Carry on with barriers. Let's list them all off.
I think that was a pretty consistent message from participants. Those kind of thoughts around the disease process. I guess and you're right. The time factor, that is something I'll have a bit more of a chat about in a minute. But yes, it's was certainly something that was raised as a potential barrier. In terms of patient factors, that largely centered around the idea that the general public have got pretty poor awareness of AxSpA. I mean, you ask Joe Bloggs on the street, what is axial spondyloarthritis, and you'll always get a blank stare. So I think it just hasn't got that same profile as some other kind of conditions. So it's I think it's fair enough that if patients have never heard of it or are unaware of it, then it's not going to necessarily prompt them to go and see someone about it, is it? So and also I think it was, participants raised a really good point that, and certainly in the early stages, that these people may actually be able to successfully self-manage themselves with exercise and non-steroidal anti-inflammatories, which again just might mean it delays them coming in for assessment. And also, I guess you think, it's tricky enough for clinicians to be able to make the link between back pain and any other kind of extra-articular manifestations. I mean, fair enough that a patient doesn't necessarily link their back pain and the fact that they've got psoriasis or whatever, and the relevance of that. I think another valid point that the participants raised was that also the fact that the general public's awareness of what an FCP actually does might also be limited. So if they don't know what an FCP does, what their role involves, that's fair enough that they might be a little bit apprehensive about going to see that person and will opt to go and see their GP, who they've known for years and have a rapport with and trust everything with. So that's also a barrier in itself if they're not going to be going to see FCPs for that. So that was probably the main bits around patient factors. And otherwise, the clinician factors, that was more so around the idea that FCPs may have limited awareness and knowledge and understanding of the clinical features and risk factors of AxSpA. So if they're not aware of that, it's not even going to be on their radar as a differential diagnosis. So I think that's something that was quite a significant point. Another thing that participants felt quite strongly about was they felt that there was a variability amongst FCPs in their level of past experience and kind of any kind of their previous clinical mileage in that area before they're moving into these roles. So if you've got someone who's relatively inexperienced moving into an FCP role, then that could make it again difficult for them to be able to be able to recognise it and screen for it. They also highlighted the fact that not just knowledge and understanding around the disease process is itself of AxSpA, but it was also the fact that if they've got limited understanding around the interpretation of blood tests and imaging, that could also be a barrier. So we were talking about before about the idea that if if they're ruling AxSpA out on the basis of negative inflammatory markers or negative HLA-B27, or let's say that there's no changes on X-ray, or potentially even no changes on MRI if they've used an incorrect sequencing. So there's a potential if they aren't interpreting that correctly, that they could be mistakenly ruling something out. So I think that, and kind of, I suppose it allows kind of people to slip through the net. So there was a lot of discussion around, making sure that people have, making sure that FCPs have the skill set to be able to adequately interpret that too. I don't know what your thoughts are there.
Yeah, absolutely agree. The trouble is it's a mess. So I think you obviously can't extricate the components here. So like you said, the disease factors plus the experience factors. I worked in rheumatology for the best part of 10 years, and it's still difficult. I wouldn't claim to be particularly great at it, but the false positives and false negatives in bloods, for example, are just an absolute horror show. So you take someone with let's take a female, for example, with axial spondyloarthritis, right? The likelihood is she's probably got inflammatory bowel disease. So you do bloods, which she's probably is HLA-B27 positive if she's got ulcerative colitis, for example. But then are the inflammatory markers raised because of her ulcerative colitis, or are they artificially lowered because she's on medication for ulcerative colitis? And so you can over and underdiagnose based on the bloods. It becomes really hard. It's just so difficult. And my when I do my courses, it's very much in primary care. My suggestion is that you don't do bloods or investigations without it being necessitated by the pathway, because of all of those reasons. So you're basing it more on a clinical suspicion, but then the clinical suspicion needs to be more based in your experience, and if you don't have that, then are you more aligned? And it's so difficult. It is difficult. Yeah,
it's tricky. And as you said, that you were feeling like that perhaps that in primary care they shouldn't be doing that. That was almost relating to there was again some mixed kind of feelings on this really. I think that I guess this probably relates more to access rather than their kind of ability to interpret it, which is almost a separate barrier in itself. There's actually variability of access for FCPs to be able to request bloods, to be able to request imaging. So in some PCNs, they'll be able to request HLA-B27, they'll be able to request full remit of imaging. And in other PCNs, they can't do any of that and have to go, either they have to go through to secondary care, or they have to get the GP to do it. And I think, participants, there were kind of mixed feelings around this. I think they felt that perhaps access to these kind of investigations and kind of blood tests, etc., they felt it was probably more of an inconvenience rather than a true barrier, if that makes sense. And that's because their rationale was that in some situations it may help support clinical reasoning, but for the most part, if there's already a strong suspicion by that clinician that this person has AxSpA, that they shouldn't be waiting for bloods and they shouldn't be waiting for imaging before they're referring on. So that was why they kind of felt it was more of a inconvenience rather than a barrier. Most participants felt that FCPs should have access to bloods, to bloods within primary care, but across the board they felt that imaging should be reserved for secondary care, and it was purely because of as we said before, about this idea of that misunderstanding around the kind of the radiographic versus the non-radiographic cohort interpreting MRIs correctly, etc. So that's kind of the general thoughts on that.
Yeah, absolutely. The other thing, just while we're hovering on investigations, I always say to people is, we're at the moment we're talking about AxSpA in isolation, and of course that it's not the only rheumatological issue. And so it's like, it's not usually AxSpA in which I'm talking about it. I'm more talking about usually peripheral joint pain, but still, you've got all these other things that can cause these issues, the rheumatological issues, and the bloods for one is not the same as the bloods for the other. And so you've got to be dead confident, and in this cohort, I suppose you've got things like, you're probably talking about semantics a little bit, but enteropathic versus psoriatic versus a primary or just a pure axial spondyloarthritis without other comorbidity, and they're going to be slightly different in what they show up. Psoriatic arthritis, for example, is going to have a negative rheumatoid factor, and so it's this. My concern, I suppose, and I probably voiced this to you if I remember correctly, is you have to know those nuances for the blood tests that you're ordering in the specific diseases and their related bits. Otherwise, you're going to get the worry is being falsely reassured.
Exactly. Yeah, and hesitating from referring on. I think it can be a total minefield, can't it? Like trying.
That's why I have a job, because it's hard. It's really hard. So I have a job. But this is why I do this. Is because it's hard for people to do. So they ask me to come and explain how a little bit of some ideas on how to do it. So I'm glad it's hard, but it's obviously no good for the individuals or the patients in this situation because there's big delay. So I'm not worried about my job running out currently. That's going to be.
I don't think you need to worry about that anytime soon.
Yeah, exactly. Yeah, so we I think we're starting to urge into the system factors, aren't we, or the environmental?
That's it.
Yeah, just finish up on those ones.
Yeah, you already touched on the idea that time's a big one, isn't it? I think that everyone knows that GPs and FCPs in primary care are time pressured. So FCPs get anywhere from 10 minutes to 30 minutes for their consults with an average of 20. So most participants felt that a 20-minute consult wasn't sufficient time to be able to adequately screen for AxSpA. So they did think that time was a barrier. As I said, we've already highlighted the fact that the variability in access for certain imaging was another one. It was also things in the fact that participants felt that FCPs have the potential to be quite isolated in primary care. I mean, often they're the sole MSK practitioner in the whole building, so there's potential for them to be feeling quite isolated. And again, previous qualitative research supports that. But I think there was also the feeling that because there's lots of different employment models as well for FCP, so I think participants felt, particularly if they weren't associated with the kind of incumbent MSK service, that there was more potential for them to feel isolated. And if they're isolated, not getting that kind of supervision and mentorship appropriately, then again, that's there's the potential that they're not talking through their clinical reasoning, having that discussion around suspected AxSpA cases. I guess on a side note from that, another thought was that regarding mentorship, let's say that for some FCPs, their mentors are the GPs that they work alongside. And if those GP mentors also may have outdated knowledge around AxSpA and saying, oh no, they haven't got positive bloods, or no, they've got no changes in the X-ray, so no, you don't need to refer them through to rheumatology. So it was this like reliance that their mentors are going to have that knowledge. So that was also raised as another potential barrier. But yeah, I think there was another kind of topic that was raised that some participants felt that there was maybe some shortcomings in the initial rollout of the FCP role, in that it was quite rapid, and they felt that maybe that had resulted in relatively inexperienced clinicians moving into specialist roles. And as we said before, if they haven't got the experience, that's going to make it harder for them to recognise that. So, they were kind of the main system factors, I guess.
Yeah, for sure. And again, we're talking about AxSpA in isolation. There's a lot of other diseases that are difficult. I remember one of my colleagues who started in FCP relatively early a few years ago. He was a very experienced clinician, and he rang me about 3 days in and was like, I've never thought I'd see this many vascular patients. And, and I think that's the issue with the time. Like, I worked in orthopedics for a short period of time, doing foot and ankle with 15-minute appointments, but that's fine because all I know it's a foot or an ankle. Like, you narrow your cohort of people is narrowed right down to a certain number of things. You've got in FCP, I think
you're getting anything and everything walking through the door.
I wouldn't do it. No, like anybody who's an FCP doing that job. I mean, kudos.
It's a really tough gig. It is.
Really.
It's that's so that they have the I think the FCPs really have the potential to play such an important role in primary care. And again, as we said, that the research today is showing that the FCP role is largely very effective. But I guess it was reiterated from participants from relating to this study that it was just making sure that we have the right candidates in the roles. That was kind of the general feel on that.
Yeah. And like I say, I would agree with all of those as themes. There's nothing there particularly that's surprising to me. So tell us about. Let's go on to more positive stuff then. So the sort of, I've forgotten the word. I was going to say enablers,
facilitators,
facilitators.
like enablers,
that's the right word.
Things, possible solutions. That kind of vibe. So as nice as it would have been that the themes married up beautifully to the barriers, it didn't quite work that way. So there was sort of five main themes. The first one was around education and training, that because we know there's kind of limited awareness from FCPs, and this is limited to FCPs. I said before, this is across the board that healthcare professionals often have limited awareness and kind of understanding of AxSpA. They felt that we need to prioritise training and education for FCPs to enhance their ability to screen for it and recognise it. So I guess there was different thoughts on how that education might look. There was some participants that felt that it should be delivered like a locally tailored program that's delivered by AxSpA champions, and your listeners may have heard of the NAS primary care champions that are kind of doing that role. So they thought that would be the most appropriate way to be able to tailor it to each trust or each region. And otherwise, there was a thought about embedding it in the mandatory training that FCPs have to do every year online, which would help to broadly disseminate it, which is, it was a positive. I guess the downside that participants raised was that I think we all know that mandatory training can be a little bit kind of click happy and just go through to the quiz at the end. So I think it's, they did acknowledge that maybe there could be some limitations with that. But I think all participants really felt that there was an opportunity to be able to incorporate education into the postgraduate FCP modules, because there's actually been a bit of a shift recently of how the competency of FCPs have been evaluated. So there's been this Health Education England roadmap to practice, which is the competency kind of framework. But in the past, FCPs have been able to go through getting that completed via the taught route through universities, or they've been able to do it via a portfolio route where they're assessed in clinical practice. Whereas, as I believe from kind of April this year, they're now looking for any new FCPs to be going all through the kind of taught route or going through higher education institutions. So I think that the fact that any FCP is going to have to be doing some sort of postgraduate module, that participants felt that was a logical way to be able to get the education in at that point. And I guess in the same sort of thought around embedding it in kind of university courses, it was the idea that it's inherently has not really made much of there's not been a lot of rheumatology education as part of undergraduate degrees. So there was also the idea that discussion around could we be incorporating that into undergrad degrees, recognizing that they already have to learn so much, but at least going into clinical practice, it would at least put it on their radar. So that was, I guess also ideas about putting some AxSpA training as part of FCP induction, those sort of things. So there's lots of lovely ideas being suggested from the participants. So I think there's, but education and training was obviously a really important topic. Another kind of theme that emerged was around AxSpA screening. So this looked at the use of things like online screening tools, like the SPADE tool, which is kind of just for anyone who doesn't know, it's just kind of a tick box online form of various kind of AxSpA signs and symptoms, and it spits out a likelihood score of of how how likely it is that this person has AxSpA and whether you should refer them on to rheumatology. So there were suggestions about kind of utilising that, which is again a nice, quick, simple tool for using in primary care in a time pressured environment. But the concern was that by just using those type of tools, I think participants felt that they also want that to be embedded in a broader clinical reasoning framework and sort of just rather than being based on that alone. And other kind of referral algorithms like the ASAS criteria and the NICE guidelines on spondyloarthropathy and the GERFT pathways, they were all kind of raised as other ways that could help with screening. And there was also kind of digital strategies that were discussed. There's a electronic pop-up tool that's being trialled in primary care that basically, if there's sufficient kind of clinical markers triggered, that the thing will pop up on the clinician screen and then ask them if they've considered AxSpA as a diagnosis. So it might be that there's a young person who's had multiple episodes of back pain and they've also got a history of uveitis, and it will just pop up. So there's those sort of things that also were suggested. And I guess the other theme was around referral pathways. So the participants emphasised the need for a clear local pathway to be in place from referring from primary care through to rheumatology. And although that might seem like an obvious one, that when you look at some of I think it was an audit done by NAS back in 2021, and they found that like a fifth of trusts had like an inflammatory back pain pathway in place. So it's not necessarily given that those sort of things are already in place. And then if it's in place, and the FCPs also need to be made aware of that and what the criteria are of how to access that. There's also things like around that referral pathway that where they have access to advice and guidance through rheumatology. So that could be a really useful resource for them to be able to tap into if they've got questions and about whether they should refer someone through. So yeah, there was that part. I'm aware I'm chattering for a while. Did you want to jump in?
Carry on. No, this is gold. No, yeah.
And then the fourth theme was around clinical governance around FCP role. So again, participants felt pretty strongly about this. They felt that there needs to be a robust governance framework in place to ensure that we're having the right people in FCP roles. They felt that FCPs really do need to be coming from kind of a background of kind of band 7 or band 8 level of working to again enhance the likelihood that they're going to be able to identify in primary care. I think that when you look at kind of the governance around FCP, it's already been, it was a really important step a few years ago when they did bring in the roadmap to practice, because that did clearly indicate a kind of the training requirements and the competencies that FCPs needed to meet. But I think they're now taking it a step further by then shifting the assessment of competencies into the universities. I think there was probably a perceived bit of variability of how that was happening. But I think by shifting them into the universities to be evaluated, that participants felt that was more kind of rigorous and a stringent approach to be able to evaluate the FCPs and make sure that they had the necessary sort of skill sets and knowledge base, etc. So yeah, and then probably the last one was around peer support and making sure that FCPs have appropriate supervision and their sort of peer support network in place. Again, I think that's been variable in the past, but I think there's been some really, really good move in the right direction that to really ensure that the FCPs are getting the supervision that they need. And I think again, things like the now, I suppose, there's probably a chance to be able to audit the supervision that FCPs are receiving against some of the standards that are now being put forward. So I think there's a means there to be able to check that FCPs are actually getting the support. But it was also things like, if they are isolated in primary care, making sure that they have got good links with rheumatology or maybe the MSK interface service, if that's kind of how they have to refer in. So at least they've got a means to be able to check on whether they should be referring someone in and having that chance to chat about it. And I guess it was also flagged that it'd be lovely if FCPs can have the opportunity to be able to shadow in rheumatology, for example, to be able to just get exposed to that and how they're assessed and how these people present. And yeah, I think that was another kind of a point that was suggested by a few participants. So I think, yeah, it's I think it just goes to show that with all those suggestions, there's an awful lot there that we could potentially be doing to help facilitate early recognition by FCPs. And you look at the work by NAS; they've already been doing such a wonderful job over these last couple of years, particularly in really pushing for some of these changes. But I think, it just goes to show that there's more that we can all be doing, really.
Yeah, no, I agree, and I think those factors are all. I don't think I'll ask you. I don't think any of those would have surprised you. Those responses.
No, I think that no, I think that there was. Yeah, I really liked where some of the conversations took us, but I think that it was perhaps in terms that surprised me. It was really about that emphasis around particularly around the governance around FCP. That was that was where participants really felt we needed to focus. So that perhaps I didn't expect so much, but I think it's it's a really valid point. So yeah, I guess it was kind of just it's nice to see how that kind of marries up with some of the plans with NAS and some of their initiatives. I just hope that at least my little piece of work can kind of support their efforts in some way.
No, absolutely, and like I said, I mean, if everything you've said is not of surprise to me particularly, which is for my opinion, great. I've not missed anything wildly off the mark. But these things are necessary for us to have the appropriate evidence base and the rigor, I suppose is the right word, isn't it? Where people like yourselves, you complete this piece of research and fine, if not blown the lid off some unexpected outcome. But in a lot of ways, that's really good because now we've got this rigorous piece of information that we can use to support how we develop things. And I think the peer support component is really important. You look at the situation in the UK with GPs themselves, and they are feeling unsupported and isolated. And then it's not a surprise that you fling some physio or osteopaths or whoever into those environments and they feel the same. It's not like that shouldn't be particularly a surprise to anybody. But with us as the MSK specialists, I suppose, then we don't have that background with the medical training that the GPs have. So then when you're talking then about these conditions, they're not musculoskeletal problems. This is a problem with the inflammatory system, the immune system. This is a medical problem. That's not what we're used to dealing with. So then if you can't then have that support locally or virtually or whatever, you're obviously going to struggle. And I think that's a really important component as much as the training. You can train till your brain falls out, but if you don't have not being supported when you have a clinical question, you're still not going to do any better, particularly.
Yeah, absolutely. I totally agree with you. Yeah, don't know if I've got too much more to say on that. Sorry.
That's great. That's really good. So I wanted to ask you just as a sort of our final little bit here. If you were to do another piece of research, what would be the follow-up to this? And then as a sort of secondary part, what do you hope is your piece of research that you've currently done? What do you hope it's now used for and as a springboard for?
I think it would be nice to see this kind of work also amongst perhaps other populations. So like I said, we've had qualitative research done in the US, but that's there were some similarities, but also some significant differences in terms of system factors, etc. So I think it'd be useful to have a look at some qualitative research amongst other cohorts, whether that be physios, GPs, etc. I guess in terms of what I hope this leads to, I think that again, there's been research done, again, particularly kind of outside of the UK, that's looked at the influence of kind of education and training and how that actually then affects the ability of clinicians to be able to identify AxSpA. I think if we can be utilising studies like that to demonstrate the value of education and training, particularly within, like I said, even physios and FCPs, etc., because they often are in that kind of frontline kind of role. I think that could be, again, further support for more education and training to be rolled out. And again, it's where we're trying to push for undergraduate in courses to be able to incorporate this. Well, if we've got that kind of evidence to show that would be really useful. I guess, that's probably my main kind of thoughts on that.
Brilliant. Lovely. So I'll wrap it up there. That's really interesting conversation. Loads of great information from you, and good discussion. Really enjoyed it. Just finally, are you on the old social media and that? If you want to direct to anybody anywhere to find more about you, if they've got questions or just want to contact you?
Yeah, I am on Twitter. I'm not super active on Twitter, but yes, you can access me on there. So if you type in Carissa Jones into Twitter, I'll probably be the only one with some sort of physio description next to my name, I think. And also LinkedIn, I'm on there as well if anyone wants to get in touch on there. But please do reach out. I think that if you want to discuss what I've been looking at, or you're looking at your own kind of research of your own, then I'm happy to talk things through.
Brilliant. Well, thank you very much. Obviously, anybody who wants training on particularly AxSpA but general rheumatology, give me a shout. That is my job to do. And there's a shameless plug for my own sort of business here, if you want me to assist you with that. So do just get in touch with me.
Well, I think we've established there, Jack, that there's certainly a need for it.
There's certainly a need, which is good for me, as we've already mentioned. It keeps me in coffee beans. That's my main concern. So thank you very much, Carissa, for taking your time to have a chat with me. Absolute pleasure to talk about and be involved in the research. Hopefully I was of use of one of your 10 participants.
Oh, absolutely. No, thank you very much for taking part, and then for your time today as well.
Yeah, brilliant. Thank you.
All right. Thanks, Jack.